is also here. Richard was kind enough during the transition this morning to hand me the Funk and Wagnalls edition of the Standard Code of Parliamentary Procedure from Alice Sturgis. So I took a moment to run through this, and I realized there were no pictures in it. So, I kind of got a little upset there, but he did have a little tag in there, and on the second page here, Richard, and this is very interesting, I'll have to ask you why, there's an 800 number. I hope that doesn't have any specific meaning to you, but I will leave that to your jurisdiction. So after seeing the 300-page book, I realized that I needed a dummy's guide to the Sturgis Rules of Order. So Ray was kind enough to print one up for me so that we could conduct elections and resolutions adequately and in a manner that we need to do. So now I know you are all waiting with bated breath for our wonderful secretary to have his moment in the sun. Mr. Secretary, would you like to approach the podium first and tell us whether or not we have a quorum? Thank you.
This is my moment for the weekend, so Mr. Speaker, we have a quorum.
Yeah. Very nice. Great job, Mike. Okay, so, all right, so we had the address of the board chair now. Now we're going to move to the address of the president. Aditi?
It seems just like yesterday that I was standing before this House as your president-elect, laying out my vision for the year ahead. A lot has happened in this year, exciting things. I think we accomplished a lot. The summary of my report is in the book, so I'm not going to kind of go over the report. I just want to say that it was really a wonderful year, and I want to thank all the staff at the Academy and the wonderful officers who I had a chance to work with closely the past year. I think the staff and the officers and all of you make the Academy what it is, and it was really an honor and privilege to work with you. As I conclude my year as president, I will pass on the baton to Dr. Peter Carazone, who will be our next president. I will continue to work with the Academy as your board chair for the incoming year, and absolutely work with the Academy long, long after that. I want to sincerely thank all of you for having given me the privilege of serving as your president. It really has been a very, very rewarding experience. Thank you.
We will now follow up with the report of the treasurer, Dr. Simonelli.
So our financials are in Appendix A, if you haven't had a chance to take a look at it. Things are actually looking quite good over the past year. We had another great year. Good growth in our net revenue, largely due to our growth with educational grants and contracts, and also our AAFP trust fund continues to grow and do well for us. It's been a great year, exciting year. I actually learned a lot in terms of the financial means of our Academy, and I'd really like to thank actually Robin Comiskey, because every couple of months I'm on the phone with her and asking her a lot of questions, line by line items, and she's been a great help, and I really do thank her for all of her assistance. Any questions? Thank you.
Okay, so we're going to move along now to the report of the AAFP delegates. I didn't know whether Mary and Arnie both wanted to come up and say something, and there are no microphones in the middle of the room. Okay. There we are. Very nice. Thank you.
Morning, all. There is a report in the handbook, and we can just go over it a little bit. I think we had a very successful time at the AFP meeting in Orlando. It was a lot of fun, and there were 3 resolutions we brought from our meeting last year, and so we outlined those in the presentation. There's Resolution 316, which was about accessibility of lab reports, and what we just did was look up the current status with the AFP website. They always list like what happened to all the resolutions that came to the reference committees. So you can read that there, that that one was accepted as existing policy, essentially. Resolution 317 was adopted at the House of Delegates, or I should say Congress of Delegates, and that was regarding confidence intervals and performance reports. And again, the Board of Directors, what happens at the AFP, for those of you who haven't been to the Academy's national meeting, is that once something passes, the Board of Directors takes all the resolutions and then assigns them out often to different commissions at the Academy. And so this particular one went to the Commission on Quality and Practice, who is chaired by our esteemed Dr. Bob Itis, who was probably, as I recall, the author of this resolution. So, but there did have action by the committee, and it was brought back to the board, and was that there's respond to CMSS whenever they give reports for stakeholder input to identify staff that they have and members of the Academy that could be helpful in the design of MIPS, and also report on those discussions back to the members. And also there was a letter sent to CMMS in response to the MACRA final rule, reminding them of the resolve of this resolution. And then the last one came up at the end of the summer when we were having the extreme price increase of EpiPen that caused a lot of consternation among patients and doctors. And so we brought a resolution that actually gathered support of 11 other chapters. And it was amended from our initial writing to make it a little more broad, because by the time the Congress of Delegates happened, there had already been some concessions by the EpiPen manufacturer. But the Congress still felt it was an important issue as far as drug pricing and the FDA's procedures for new devices and also pharmaceuticals. So you'll see the resolve that was brought from the Congress after amendment by from the original that we brought them.
So the elections, as most of you know, Mike Munger from Kansas was elected by the Congress of Delegates as our president-elect, and board directors, you can see in the handout, Robert Rasper, Leonard Reeves, and Ada Stewart. Obviously, there'll be new elections coming up this year. The meeting will be held in San Antonio starting on or about, I think, September 10th, continuing through the end of the week with the FMX as well. So anyone can make it to San Antonio, not only for the scientific, but if you can come a few days early, you're welcome to join us in terms of being part of the Congress delegates. We always enjoy having other members there. New Jersey always hosts a evening wine and cheese as well, and it's really informative. For those who have not been to a Congress of Delegates, particularly younger members of the New Jersey Academy, it's really an eye-opening experience to see how our deliberative body operates, how there's debate, discussion, and you find it very valuable if you can make it out a couple days early.
I'll also thank our alternates, Dr. Schonbaum and Dr. Bernardo, and again, echo Warney's plea for all of you to come to San Antonio. Any questions from anybody regarding delegates' report? Well, let's just see what was on the website regarding their current status. And I see Dr. Itis rising too, but that there's apparently work going on behind the scenes with legislative policies and working with the FDA to improve the availability of drugs and devices. I can't comment on that specific. It certainly isn't a solved situation, I think, completely, because there aren't easily available alternatives still.
Bob.
I'm sorry, Bob. We're working on getting another microphone. So, and if everybody that wants to, ask a question or whatever uses the microphone, we are taping this, and they will not pick that up unless you're using the microphone. So,
actually, I prefer this because the height controls are very easy to use right now.
very nice.
So, as Mary said, it was modified because the original resolution, I can't remember the exact wording, but it had to do with pricing controls for pharmaceuticals that are life-saving where there is a non-competitive environment. And there was very strong support, as Mary said. And John, you might want to comment on this, but I think there was strong support from the board, and there was letters that were sent to the appropriate regulatory and legislative bodies. Unfortunately, the EpiPen still costs $600, and the generic is not much cheaper. They did, essentially as a PR ploy, come out with these coupons. Right, but that was why I came up here. There is actually a $6 auto-injectable epinephrine pen by the brand name of Adrenaclick. I believe it's only available at CVS. So Claudine got it from CVS. So if you want to save 594 big ones, that's the way to go.
Did Dr. Cullen want to add something?
Well, hello, everybody. I'm John Cullen. I'm on the board. This is a really important issue. Obviously, this is something we need to address, but it probably will need to be a legislative fix because it's something that's difficult to handle otherwise. I know that unfortunately it's very complicated because there's several players involved, but obviously this is something we need to address. And just the pharmaceutical prices in general are just high and getting higher. This is something that's going to be important to talk to your legislators about and to educate them, because, like I said, this is probably going to be something that's going to have to be a legislative fix.
Thank you. Any other questions? Okay, seeing none, before you go sit down, Dr. Cullen, we're going to call up our visiting dignitary from the AAFP, John Cullen. John Cullen is a family physician in Valdez, Alaska, is a member of the Board of Directors of the American Academy of Family Physicians, and as an AAFP board member, Dr. Cullen advocates on behalf of family physicians and patients nationwide to inspire positive change in the U.S. healthcare system. Dr. Cullen has practiced the full scope of family medicine in a rural community of 4,000 people in Alaska for the past 21 years. Dr. Cullen works in a small group practice and is both Chief of Staff and Director of Emergency Medical Services at Providence Valdez Medical Center. He's been actively involved in residency and medical student teaching for more than 18 years, providing comprehensive training in rural health care, and he is an associate clinical professor at Dartmouth University. His bio is in there. I will not read all the other awards, etc., other than the fact that Dr. Cullen was elected the Alaskan AAFP or AFP Family Physician of the Year in 2008 and was a finalist for the AAFP Family Physician of the Year Award in 2010. Dr. Cullen?
All right. So should I just tell you to advance, or do we have a clicker?
Oh, there's a clicker right up on the top. Papers out of your way.
All right, so this is where I live. This is Valdez, Alaska. So we're about 350 miles away from the nearest metropolitan center. And this is a really pretty picture. That's what it looks like right now. Last January, it looked like that. That's what it looks like when it's 0 degrees Fahrenheit and winds are blowing 100 miles an hour. It was really an interesting time because it had rained, and then it got really, really cold, and then the winds came up, and I was driving to work because we still have to work even when it's we call them wind events. All of a sudden, there was this big blast of snow. I couldn't see anything, and then out of the snow came this dumpster traveling at about 30 miles an hour in the other lane. And which kind of brings up how I feel right now politically. It's a really interesting time. I mean, this is one that, for the first time in, at least the last 20 years, your AFP board is meeting weekly just to figure out what's happening politically. This is actually the best term I had to describe this was from Sean Martin. He called it a dumpster fire. And the idea of a dumpster fire in sports is that it's when a team really plays poorly, everybody is arguing with each other, and nobody wants to take responsibility. And that's kind of what we've got, is we've kind of got a very similar situation. And I would love to be able to say that nothing is going to happen from all of this dumpster fire that we've got going on. Unfortunately, I don't think I can. We were a little bit surprised when the House passed the AHCA. We didn't think that they were going to be able to accomplish that. And I hate to say it, but I think there's a very good chance that the Senate will also pass a similar bill. Whether or not they can reconcile the two is going to be the big question. I mean, there's several questions. One is, are they going to have enough senators to pass an AHCA version out of the Senate? Our Senator Lisa Murkowski from Alaska is going to be one of the ones that's going to be determining whether or not that happens. But the way that the House worked is that they apply a lot of pressure on the Republican representatives to get them to vote for this. Otherwise, they threaten them with being primaried. And so I think that the same pressure is going to be exerted on the senators. I think there's a very good chance we're going to see something coming out of the Senate sometime in the next month. They're looking at early July as far as actual passage, and then bringing that back to the House. My personal feeling is I really hope that does not work, and that we have a bipartisan approach to health care, which is what needs to happen. But I think that at the same time we have to be aware that this is in the cards. I don't know about your patients. My patients are very anxious about this. For us, Medicaid expansion was a really good thing. Before Medicaid expansion, we were doing a lot of charity care because people just were not able to pay for health care. And since I covered the emergency room as well as having a private clinic, I would either see them in the clinic or I'd see them in the emergency room. The emergency room cost would be 10 times greater than the clinic cost, and so it was going to happen one way or another. And so we ended up doing a lot of charity care. Family physicians really are the ones that keep the system going when it's non-functional, and unfortunately we may be kind of going back into that a little bit. But one of the things to bear in mind, and this is actually a paper from, in 2006, Richard Young and Jennifer DeVoe wrote this paper looking at the cost of health care over the next, well, at that point it was 30 years. And what's remarkable about this is that we are still following this curve. And so what this is there we go. This is average income. This one is half average income. And then this line right here is the cost of premiums plus your out-of-pocket costs. And what they predicted was that by 2018, that the average insurance policy plus out-of-pocket expense would equal half of the average income, and we're right there. I don't know about New Jersey. In Alaska, we're probably just a little bit above that. And so if this continues to hold true, we're going to see this increasing cost in medicine. We've got to get control of this. This is something that's really important. And one of the reasons why that's happening, and this is the last time that this graph was updated was in 2010. These are things I saw a long time ago, and I just held on to because they were just so dramatic. This is the growth of physicians and administrators. The growth of physicians, the physician growth is the blue line at the bottom, and the red, of course, is the administrators. So if it ever seems like you just have administrators looking over your shoulder like all the time, this is why. And this is one of the reasons why healthcare is so expensive, is because of this growth of administration. And that's one of our priorities, is that we really need to cut down the administrative overhead. So I include lots of pictures of ice, because when I bring this up, everybody gets a little anxious, and I really do believe in ice as far as therapy goes. That's actually within our city limits. Oh, thank you. So that's, did it click? Yeah, yeah. So that's actually within our city limits. But the thing is that we really do need to fix the ACA. The ACA has been very successful in a lot of ways, but there's a lot of areas where it really did not work well. And this is what we've been really pushing on within our advocacy effort in D.C. State marketplaces have small risk pool. How is your state marketplace doing here? Yeah, so we're down to one provider. And part of the reason why they are not working well is because the risk pools are just too small. And when the problem with that is that when you have small risk pools, then it's really hard to figure out how much it's going to cost the insurance companies, and they make an error on the side of making money, obviously, because they're for profit. But that raises the prices. And so somehow we need to expand the risk pool so that there's more people covered in that. The other problem we had, of course, is that there are a lot of people who were deferring care until they were able to get on insurance, and so our orthopedic colleagues have been doing very well doing hip replacements as a result of this, but unfortunately that's really raised the prices. That should get better if they don't do anything, but then the other problem that we're having right now is there's just so much chaos. It's that dumpster fire idea. There's so much chaos that all the insurance companies are raising their rates just to compensate for the uncertainty of the market. And so just the chaos is causing a lot of these markets to fail. We're seeing real problems with narrow networks. In Nebraska, for example, all the physicians in the network are on the wrong side of the state, so they offer physicians in network that are 300 miles away. I mean, there's these crazy things that are going on within the insurance companies. High deductible plans are really taking hold, and that actually is a limitation in terms of access to care because it costs a lot of money. Not only are they paying a lot of money for insurance, but then they have to pay out of pocket for the high deductible plans. And then the Medicaid expansion, like I say, for us at least, has been really good. So that's also within city limits. So payment reform. So this is kind of what the Academy is really working on at the moment. Payment reform, we really want to increase the primary care spend. And if you look at it, systems around the world that are much cheaper than ours and has better quality, all of them spend much more on primary care. And we're talking about 30% of the money in healthcare is spent on primary care. That seems to be the sweet spot. We're way less than that. And so we need to do that. Some of our efforts are working. We've seen the family physician's average income has gone up by about $30,000 in the last couple of years. So a lot of the things that we're doing are working. I don't know if that's holding true in New Jersey. So one of the great things about doing this talk is that I get to share experiences from other states. You know, Rhode Island has a mandated 10% increase in primary care spend. That's actually worked fairly well for them. There's a lot of physician-led ACOs in the Midwest that are doing very well, and that's been a big reason why they've been able to have increases in salary. It looks like the physician-led ACOs are the only ones who are doing well, though, and so the hospital-based ACOs are not doing nearly as well financially. Do you have any physician-led ACOs in New Jersey? And that's really important because for a lot of places, that's the only way you have any traction against the insurers, is if you have enough physicians in your physician-led ACO that you can actually negotiate for prices. And so that's something I would encourage. I know that in Rhode Island, they have a very strong one that has a lot of physicians in it, and they're able to negotiate for prices. In Texas, it's the same way. They were able to negotiate much higher prices as soon as they had a significant percentage of the independent physicians involved. So it's there are some ways to work against the insurance companies. We're working really hard on MACRA, and remember that MACRA is one of those, just like ACOs. This was a means so that family physicians get paid more, and I know that it seems like that's not the case, and the problem is that, you know, there's a saying that an elephant is a mouse built to government specifications. And unfortunately, like everything else, you know, MACRA was really a fairly simple idea initially, was to pay for primary care more, and it's kind of morphed a little bit. But it is still the idea there is that you're paying for not per visit, but by quality. And there's also a saying about MACRA is that it's a little bit like the Hunger Games. You know, everybody's competing for the same resources. In that kind of a scenario, family physicians are going to do well. Because we're not competing against other family physicians, we're competing against all the specialties. And these are all things that we do anyways. I mean, these are a lot, if you look at a lot of the things that you can report on, they're all things that we do anyways. And so we should do really well. We need to reduce the administrative complexity. How about DPC, direct primary care? Is anybody doing that? I heard last night that it's not very effective in New Jersey. Is that the case? And why is that? I'm curious.
I think the risk of dropping everything and starting out and the competition of that.
I think that it's something to look at closely. And one of the reasons why is that, one is that it gives you an outlet. If you are having difficulty working with your insurers, it also makes them a little bit less complacent. If there is a mechanism which you can see patients completely out of the insurance arena, then that gives you a little bit more power just as a medical specialty. If the AHCA goes through, and all of a sudden we have a lot of people that do not have a marketplace and do not have Medicaid expansion, there's going to need to be some other form to see them. And actually, DPC works fairly well for that. It's a fairly inexpensive alternative for people to have good care.
There's also two other restrictive things in New Jersey. One is, compared to other states, is we're not allowed to dispense medication, and also some lab restrictions, which are other avenues of revenue in a DPC, were restricted in New Jersey.
All right. Well, you need to change that then. Sorry. What I do think is going to happen regardless is that what's happening in D.C. is just making the federal government much less efficient. I mean, it wasn't as efficient before, but it's all these changes are making things less efficient. That means that a lot of the control is going to devolve down to states. And so having a strong state legislative advocacy is going to be very important for your academy. And I realize that's in addition to everything else you're doing, that you don't want necessarily to do one more thing. But I would argue that being involved with legislation, being involved with advocacy is one of the best ways to avoid burnout that there is. So one of the things that happens to us is we feel like things are just being done to us. And if we can fight against that, and that's what advocacy is, it really makes a difference. And that's been my personal experience as well as experience of others. So I think that you will need to get involved legislatively. You've got the stories, you've got the patient stories. And that's the thing, is that if you go to your state legislation and you talk about how you need to be paid more, that's not going to work, because all of legislators feel that physicians are getting paid too much as it is. But if you talk about it in terms of taking care of their patients and reducing the cost of health care overall, then that's going to have some traction. And like I say, you've got an example of other states around you that are actually have managed to do some interesting things. And like I say, with just increasing the primary care spend and changing legislation so that the DPC becomes more viable. All those things are doable. And I think that, I hate to say it, but just given the situation we're in, that's going to be something you have to work on. And I know you're doing a lot already, but it's fun. Being an advocate is really fun. I've had a blast. And like I said, it's really the answer to feeling like you're just having things getting done to you. All right, more ice. So this is all on the Valdez Glacier, and we have icebergs. So this is, like I say, this is within our city limits. It's right by our airport. And so we have icebergs melted into the ice just right there. So workforce, we've had more family physicians matching this year than ever before. The big limiting factor right now is the number of residency slots, and we need to increase those, and so we're really pushing for the teaching health centers. I'm sorry, I'm doing two different things at once. But we still need more. I mean, we're still looking at a significant deficit of family physicians over the next 10 years. And what I see, at least, is that that's not being made up with PAs and nurse practitioners. In New Jersey, is there a tendency for nurse practitioners and PAs to go into primary care, or are they more going into specialty care? You know, what's interesting is that one of the reasons why the nurse practitioners were able to get such autonomy was by saying that they were going to be the answer for the physician shortage. Sorry? Yeah. Or even if they had the best of intentions, that's unfortunately what happens with a lot of that is that they really what they learn is an algorithmic kind of medical care, which does not work for primary care. From a technologic point of view, I don't know if you heard about IBM Watson. So IBM Watson is it's a somewhat artificial intelligence. Was very good at Jeopardy. They're trying to make it a source for medical information. They decided that they would try something easy and do primary care as the first step, and it absolutely failed. They couldn't do it after 6 months, or it was maybe 9 months. Could not get it to work. And so they thought that maybe that just wasn't a possibility with artificial intelligence. They were really rethinking what they were doing, so then they tried oncology, and they had it all figured out within 2 months. Primary care is tough, and it's really tough to do just from a purely algorithmic kind of way. And algorithmic medicine, that works really well for IBM Watson, and that's things like oncology or rheumatology or endocrinology. All those things, I think, are at risk because of the changes in technology. But I think our place is secure. So that's what it looks like now. So it's so we're really working on practice enhancement. There's something called the advanced primary care functions, and those are ones that we're really. And part of this is our legislative arm. Again, the advocacy, explaining to legislators what it is that family physicians do, and why we're the answer for reducing cost. I said back in it looks like those got a lot of order there. Other issues, one of the things that we're very concerned about is the U.S. Preventative Medicine Task Force may be changed or defunded, and that's something that obviously we take as being that's a real assault at this point. We're fighting very hard to make sure that stays on. You probably have heard that there is a vaccine task force that our president has set up that's mainly staffed by people who don't believe that vaccines are safe. And then there's a lot of issues regarding reproductive health issues that we're working against very intensely. And then we're also really working on the clinical expertise. And one of the interesting things, one is we want to make sure that everybody stays up to date and working on education. We're also trying to figure out how we can communicate science and scientific knowledge to the general public. And that's something that we don't seem to be doing as good of a job about, which is why we're having the issues with vaccine denial and things of that sort. And like I said, there's just a lot of things going on in Washington. I mean, we're meeting weekly in order just to keep track of all the things that are happening. But despite that, I think the important thing is not to get too stressed out about it, but just chill. But not too much. I mean, you have to be angry, because in order to be angry, I mean, what happens with being angry is that you can use that to drive your agenda. And I think that's a position that we're all in. And whether it's working in our own clinics, to preserve our own clinics, taking care of our own patients, or whether we do it at a state level or a national level, that's really important. And speaking of advocacy, there's a program called Speak Out. Are you all familiar with that? So Speak Out is a program. You go on the AFP website and look at Speak Out. It gives you updates about what we're trying to deal with legislatively at the time. It gives you the numbers and the email addresses of your senators and representatives. You can do it. You can set it up so that it works for your state as well, so that your state issues can be posted on there. There's usually a statement that is what we're trying to get out, and so you just have to sign your name and send it. It takes 2 seconds. But it increases our voice dramatically nationally. And so something I really recommend that you all do, everybody should be involved in this. Because right now, family medicine encompasses about 130,000 physicians, students, and residents. I mean, we're one of the biggest specialty organizations in the country. But we need to speak out. We need to be really vocal. Fam MedPAC, we're up to very close to $1 million. We may have crossed the $1 million threshold. That's important because that's our political action committee. You get a different designation. People look at you more if you're over $1 million. Just as a comparison, of the terms of the specialty organizations, we're still one of the lowest, despite our numbers. Emergency physicians actually spend a lot more per physician on their political action committee. I think the anesthesiologists are the most. They're about $20 million. The general surgeons are right up there. So are even the neurosurgeons. And you wonder, why things happen the way they do in medicine. A lot of it, I hate to say it, but it has to do with those political action committees. We're going to be changing how we do things. We used to just try to funnel money to various candidates that would be useful for us. We're going to change it now so that we're not going to give money to people who are working against our interests. And so we're big enough now that we can start to do that. But that's something else that I would really strongly recommend, that if you're, in terms of advocacy, it's really important to support this, because this is what improves. It's not that we're buying votes, but it gives us access. And then once we get the access, then we can use our patient stories to really, really drive the discussion. The other one that's really good is the State Legislative Conference. And the State Legislative Conference, I'm not sure where it's held this year, but it's a chance for all the states to get together and share what they're doing legislatively. And did anybody attend that this last year? Did you get any good information out of it? Yeah, that's because it's a chance for us to share things. And there's actually also, along those same lines, is we do have a clearinghouse for information that all the other states are doing. So you can just go in and get somebody else's, another state's legislative bill to give to your legislators. So you don't have to recreate the wheel. All this has already been done, and you can just grab that and use it. How much time do I have? I could just talk about the stuff. Yeah. There's so much going on that we have to kind of try to define a little bit about what we're doing, but obviously these are all things that are affecting us. The undervaluation of primary care codes, we're working really strongly on that. Trying to get, and along with one of the bills that you put forward at the Congress of Delegates, having electronic health records that actually talk to each other. Again, that's probably going to have to be a legislative fix, because the vendors themselves really have no interest in having them talk. Just trying to get around having to do prior authorizations for a lot of different things. And then unfunded mandates like the payment for translation services. Those are all things that we're working really intensely on. we want to get our core measure sets to actually measure things that are useful, that actually are valuable, rather than just measure things that are easy. And there's a core quality measure collaborative, and it's several organizations that are all getting together, all primary care organizations as well as insurance organizations, to come up with a meaningful use of core measure sets. If we're going to measure something, it might as well be have some value to us and the patients. And we're just trying to really work on simplifying the administrative overhead. And then pharmaceutical prices. And again, this is going to be a legislative fix. What everybody in D.C. wants right now is lower premium costs. They want better coverage for their constituents. They want more people covered. I mean, that is a general theme. And I think that as family medicine goes, we can really show that we're the answer for a lot of this, especially when we talk very directly about how much medications cost. And I think that we're actually the only ones who are really doing this, at least at a national level. It was very interesting when I went this last time and went and lobbied. The whole pharmaceutical prices, why pharmaceutical prices were so high, was something that really had not been brought up, as near as I could tell. And so, and the other thing too is just kind of along the same lines, is that the Republican Party in particular has really not been educating themselves about healthcare issues up until this point. I mean, they were basically in a denial phase. But really, when they were talking about their healthcare plan, it was a 30-page document that had general outlines, and that was about it. That was the better way. And so when I went in February, everybody was in a panic because all of a sudden they had to figure out healthcare. And they're still a little bit in that panic mode. They're trying to educate themselves, and so this is a really good time to go in as what we do best, which is to go in and counsel people. And I think that if you look at your legislators the same way as your patients and looking for that teachable moment, and this is a really good time to do that, because they're really, I do think that most of them are trying to do the right thing, but really they're operating from a point where they really did not have adequate knowledge before this point. All right, any questions?
Good morning. Hello. I'm Tom Ortiz, fan physician from Newark, past president. You brought up two topics that are very close to my heart. First of all, let me congratulate the Academy on the work that they've been doing to advocate for our interests, particularly with the advent of the ACA and, of course, MACRA, both of which we were intimately involved with planning out. And I think some of the message has to get to the physicians that, we're at the table at these conferences and at with these legislators. And I think that the doctors don't appreciate that as much as they should. Two things. One, insurance belly aching about raising premiums. And the Republicans were very successful at attaching Obamacare to the rising premiums, which we know they had nothing to do with each other. The insurance companies took it upon themselves to hurt Obamacare by raising premiums. When you have insurance companies that make $6 billion a year and complain about losing money in the exchange, I don't think there's any excuse. I don't know that we've, as an academy, have got that message out to the public that the two are two separate issues. The insurance companies are doing what they want to do on their own because they're very greedy people, and they not interested in covering all the people in the United States and not participate in our idea for universal coverage. And the other thing is the pharmaceutical companies who are raking in billions and not putting anything back in the system, either in the IT part of it or anything. In fact, they've taken away a lot of the perks and things like that we've had in the past. So I just want to know, can the Academy do a little bit more? And our Academy, it's apparent that we have to be stronger advocates in our own state with our own legislators. It came out last night in the board meeting when we had a little presentation on a survey that was done on our membership. They want us to be advocates for them in Trenton and at the national level, so that our interests are represented, and some of these issues that I just mentioned can come to the surface and people can understand better, the public, that we're doing so. So can the Academy help us in those two particular areas?
Yes. There's a few things going on. You know, there's a rich question because there's a lot there, and in terms of the for-profit insurance companies, even the not-for-profits for that matter, this is one of the big things of our time. Is are we going to continue to allow those kind of profits to be made on our patients or not? If all of this collapses, and let's face it, that's a really strong possibility. If the AHA is passed, then things may collapse. If it isn't passed, then things may collapse. What will probably end up out of that is a single payer, realistically. And so we've actually, as an academy, we have been drafting what a single payer would look like that would best benefit our patients and our specialty. And so we've spent quite a bit of money on this. And the idea is that if everything collapses, then we'll have this document that we'll be able to, and it'll be more than a 30-page plan. It'll be a comprehensive plan about how to go to a single payer, just so we'll have that available. And so that would be, and you know, we don't want that to happen, obviously, because there'll be, if it gets to that point where things absolutely fall apart, then that will be a bad thing for everybody. But it was interesting is when I was in D.C. in February, that's the impression I got from everybody as well. And this is from very conservative Republicans. Well, everything's going to collapse and then we'll go to single payer. And so, which was the first time I had ever heard that admitted. So I think that we may be moving that direction one way or another. And in terms of what the Academy can do to help, I think that there's quite a few things within the like they say, there's the state advocacy summit, which I would really recommend that you send as many people to as you can. It's a great time, and it's a lot of fun. But more than that is you really get to talk to everybody else, other presidents, president-elects, members of the board that are actively engaged in projects and how they went ahead and did it. And I think that a lot of it is just learning that, you know, what the game plan. And realistically, you could probably have them come down and give you a hand. I mean, you know, we're family docs. We're very collaborative, and then on top of that, there is a clearinghouse. You can just get the legislation and talk to somebody to put it forward. You may need to have a family physician run for your state legislator, and because that.
You talked a little bit about advocacy for DPC. And a question I have is, with a little bit of a tremor now in the DPC with Q Lions going under, what's your take on that, and what do you see the future of DPC?
Yeah, and I think that we're still trying to figure out what actually is happening there. So I'm not sure I can give you a great answer, except that the nature of DPC is that it is something that works really well on small scale, and when you try to scale it up, it may not work quite as well. Again, the whole idea with that is to try to keep your administrative costs as low as possible. But I don't see that as being the end of DPC by any means.
Hi, yeah, good morning. And Elizabeth Liu from Rochelle Park. And my question is, for this year, May of 2017, the state has mandatory the narcotic control, you know. So when we check the PMP program, it would be nice that if any one of those patients turn out to be positive for, let's say, cocaine or whatever, marijuana, very popular, it will be alarmed as well. So I'm not sure is there any program in place from the from the whole state to implement this, so that we're not going to be knowing who has a positive report before. And then we'll be penalized, God forbid, and by writing something, narcotic, for instance, to those patients. So it's really kind of like not in a very good scientific base, and I have to say, and it's not fair to kind of like just judge physician because we don't know. So I hope that all of us can maybe make suggestion to the state. The lab should be mandatory to report all this, and the central collection of the data should be posted in that PMP program.
I think it's a great idea. Yeah. Because that's one of the problems that we see is that when you talk about how government works, they don't go by data or what's scientifically appropriate. They just go by what feels good. And kind of, I mean, I hate to say this, but they go by patient stories. And what's one of the best patient stories out there right now is, you know, my son, my daughter died of an opiate overdose. And it was because of the medications they got from a physician. And that's a very powerful story, and that's what we're working against. And I know in Alaska, they wanted to require everybody who was prescribing narcotics, they would have to take 12 hours of CME just on narcotic prescribing. And I said, that's a great idea. That's awesome. You guys should do it. I'm not going to do it. And, you know, I'm the only doctor in 350 miles, but it's, go ahead. You know, this... but they decided they really wanted me to prescribe narcotics after all, so they cut it down, I think, to 2 hours or something like that. But it's so I think the important thing with advocacy is that the fairness is important. That does play well, but you also have to put it in context of a story, because that's what legislators go by. It really is, and it's a story about patients, and it's your story. And you need to have data to back up what you say, but a lot of it comes down to stories. And that's not necessarily right, but that's just the time we're in.
Yeah, I was visiting a patient the other day, and they thought they were showing me the report of their colonoscopy. In reality, they were showing me the bill, not only for the colonoscopy, for the other tests too. And the GI guy had charged $4,000 for the colonoscopy. And he also showed me the lab reports, and it was a $125 bill for the CBC and, you know, those kinds of numbers. So my question is that I don't think it's just the overpricing of drugs or the overpricing of hospitalization. I think the overpricing of medicine in general in the United States. And so my question is the AFP working with the AMA collaboratively with other larger groups to sort of see if we can attack this problem as a totality? Last night you mentioned how small our PAC group is because we only get $1 million a year. So we have to somehow look at who are the main players to make a change in the way that we deliver medical care at a cheaper price. So my question is the AFP have any active plan with the, I don't know, any bigger organization than the AMA to help facilitate that?
That's a really good question, and this is one of the big dramas that's played out over the last 10 years. So the reason why colonoscopy, he can charge $4,000 for a colonoscopy, is because of something called the RUC, which is a commission. It's a committee in the AMA that sets prices for procedures and office visits. It's an advisory group that the CMS then uses, but it basically that's what sets prices. And one of the reasons why family medicine and primary care has been devalued over the years is because of the way that the RUC is structured, which is you have one representative from every specialty and subspecialty. And so we have one vote of this entire thing. And there's a lot of backroom discussions. You know, if you support me for my colonoscopy prices, I'll support you for your ENT procedure. And that is what has driven up the price dramatically. And so a few years ago, we, being very frustrated with how this was playing out and that this whole system has been very bad for the healthcare of our country and has been a big part of the reason why the healthcare costs have increased, we threatened to leave the RUC and to just actually take off on our own to work directly with CMS. And that is still a possibility. That's still out there because we agreed they tried raising our rates because the idea is that by leaving we would break the house of medicine because we are a significant portion of the number of physicians in the country. And this was a big deal. We ended up staying in because of assurances that were made that things were going to change. They haven't changed. And so this is going to be one of the big things that's still going to play out over the next couple of years. There are members in CMS that are actively talking with us about creating our own codes. So we would have primary care codes completely separate from the regular codes that the specialists use. And so that's going to be the question is whether we stay in or not. I wish I could say that it was all being done in a collaborative way. It's really not. This is one of those areas that we're fighting pretty intensely. By the way, I do colonoscopies. And I mean, again, we're the only game in town, right? So I make more money in doing the colonoscopy in the morning, which takes me in a half hour to an hour, than I do for seeing patients the whole rest of the day. And you know what? It is the easiest part of my day. It is. I was just having a discussion with a gastroenterologist about it the other day, and I'm just saying, that's my easy hour is doing the colonoscopy. I get paid so much more for that than for doing anything else. It's just absolutely ridiculous. We've got to cut down the prices of procedures.
You mentioned on a previous slide about payment for translation services. I was wondering what the AAFP is doing in regard to try to offset some of the cost of that service or providing those services from the physician or from the practice onto insurance or someone else, because as we know, the cost of translation services can often even exceed the reimbursement for the office visit that you're providing those services for in the first place.
Yeah, absolutely. I mean, this is one of those unfunded mandates, and that's something that we need to change. So we are working with CMS really closely on this one. And I brought that up specifically because, again, that's a fairness issue. That's just not fair. Right. Absolutely.
It's funny how history repeats itself. I just wanted to, some of us who have been around here for probably a number of years, recall that we actually brought a resolution, probably it's more than a decade ago, to the AFP regarding leaving the ruck, and went through all that discussion. I believe we also brought one about having our own codes. And so, it's interesting to see that coming back up again, but we thought of it here a long time back. But the question I had was, I think you were right on target with the fact that doing advocacy and being involved in organizations like AFP and NJFP really does help us to prevent burnout, at least for myself too. That's really helped over the years to feel like you're doing something, even if it doesn't always get us exactly where we want to be. And so I know we heard in our small survey that Tom mentioned earlier is that even though we're doing a lot of good things, that our members don't totally understand that, and also that there's a great deal of people who are either in a totally shut down mode by the hassles of practice or close to that level. And so I suspect that is maybe also consistent across the country to a degree, although maybe worse in our part of the world. So what is the AFP doing? I know there's been some initiatives, and Dr. Knight, I believe, at the AFP has been charged with looking at burnout and how we can work as an organization to help prevent that and help to bring our members into the fold of doing advocacy or doing other things that will help us not to burn out before our time. Thanks.
We actually, we set up quite a bit of money. We budgeted quite a bit actually for burnout prevention. And so that's going to be education. That's going to be some studies. We're collaborating with the ABFM, with Health as Primary, and with the AMA on how to prevent burnout. And so there's actually quite a few programs out there. This is something that is, it's just even a few years ago, we were having a hard time convincing people that it was something that existed. And unfortunately for family docs, and I actually have a talk tomorrow, I'll be talking about this a little bit, but more than half of us are feeling burned out. But yeah, one of the ways that you can combat that is with a sense of agency. And agency means that you have control of your own fate. It's not that you are just, things are being done to you, but that you are actually in control of what's happening. And that's advocacy. We're really good at this. When we kind of let ourselves become a little bit Machiavellian, family physicians are really good at advocacy about talking with our legislators. This is what we do, right? I mean, we talk to patients all day long. And if you look at your legislator as a patient and just use all of the tools at your command, because we know how to educate, we know how to convince. This is what we do. We should be a lot more effective than we have been. And it's really important. I think it's something that everybody should do. It's an amazingly cathartic experience to go and advocate on behalf of your patients. And I have to say, my legislators in Alaska, I have to fly there only on good weather days. Because it's about 1,000 miles away from where I live, is where the capital is, and there's no roads. So you guys really don't have any excuse, right? You want to use this one?
I could use that one. Sleep at the wheel over there. So, you did speak, John, about the rise in executives versus, physicians, family physicians, I guess across the country, and showed us that nice graph. One of my concerns, particularly in the state of New Jersey, and you could probably speak to this from a small town in Alaska where there's only one hospital system, but there's monopolies that are being formed in the state, and I'm sure there are in other parts of the countries where hospital systems are, obviously merging. Insurance companies may or may not be merging, but at some point, one of them or two of them may become the only games in town. So how do you deal with prices? I mean, if I were an insurance executive and I went to hospital system A that has 20-some hospitals in the state, monopolizing maybe a half a dozen counties, and you go to them and you say, well, we're going to give you X for your services, and hospital system says, no, we want X plus, because if we don't get X plus, try to sell policies in this county without us being part of it. I mean, I think that contributes significantly to the rise in healthcare, particularly with the all wonderful facility fees that everybody seems to pay for, which doesn't make sense in my mind at all, unless they're going to pay for my facility, which is in some cases better than the facilities that they're getting facility fees for. So how do you deal with those kinds of monopolistic setups? How do you deal with a hospital? They're the only game in town. How do you handle that kind of thing, or what you've heard in other states?
Yeah, really good question. I guess I think there's a couple of answers. One is that you could wait, because I think that the facility fee is probably going to end up going away at some point. And at that point, being an employed physician versus being an independent physician, I mean, that dynamic is going to change. And hospitals are not the most efficient way to deliver medical care. Really, it's if you look at it, it's office practice is really where things are at as far as cutting costs. Technology is improving radically, and so we're going to be able to do more and more in our offices. I mean, medications are not only medications, but there's a lot of things that we'll be able to do in our offices that where you won't need to have that hospital-based care, and whether that is going with like ultrasound, for example, which I started doing ultrasound 20 years ago, and it was really like looking through a really dark stained glass window with lots of dirt on it. And now the images you get are just absolutely clear. And the machines, you can get a really good machine for $5,000 or $10,000. Those are things that we'll be able to do in the office. There's going to be new tests coming out for colon cancer, so even colonoscopies may be something that will be done a lot less frequently down the road, because there's going to be some genetic stool tests, actually, that are going to be more effective. So there's a lot of things that are happening that are going to really cut the profit margin for hospital-based medicine. And if we're looking down the road, eventually, I think it's going to really come back to us. We'll be able to provide the care for a lot cheaper, and given the costs that are increasing in medicine, we're going to be really the value proposition that's going to take over. As far as the monopolies, that's a hard one. I mean, that's the problem about allowing free market medicine, is that then things kind of develop into kind of sometimes go down to the common denominator. We have one hospital system where I am, but unfortunately, what it sometimes takes is having an enlightened administrator that you work with. And I've worked with some really good ones and some bad ones. And what I usually tell our medical students is the most you can hope for in a hospital administrator is that they're benign. But sometimes you have an enlightened one. There was a Blue Cross down in the D.C. area that came up with a program that just paid family physicians about $50,000 more a year just to do practice management. And with that, they saved a tremendous amount of money. And so But unfortunately, again, what that took is an enlightened administrator. I'm not sure if that answers the question. I do think that the ACOs may be a structure that we can use, and that's being used in other places. So ACOs, the nice thing about an ACO is that you can talk about your prices and you can negotiate as a block. Otherwise, you're at risk of having antitrust violations if you talk about how much you're charging. But if you do it through the structure of an ACO, then you actually have a lot more clout. And so a lot of places, what they've done is they've just banded all the physicians, all the independent physicians together in a group. And then they can negotiate higher prices, and then they become a block that is maybe not on par with a big hospital group, but it can be. And so I think that's really an important structure for us. The other thing is that what you see is when you have a strong ACO in a state, or several, that the employed physicians are treated better. Because at that point, then the hospital wants to make sure that people stay employees and that they don't become independent and join the ACO. And so it's one of those things that it makes life better for everybody if you have a strong independent body. But I think we are going to have to end up being grouped together. That's really important. All right. Anything else? All right. Well, thank you very much. I'm really happy to be here in New Jersey.
So Dr. Cullen has one more duty. He will now confer the fellowship on two physicians who I'd like to come forward at this time. Dr. Kennedy Gonti and Dr. Julianne Luco. How do you want to do this? You're going to do that down there? Okay. So just some other interesting facts about Valdez. I was looking that up last night while they're preparing for the fellowship awards. Valdez is the northernmost point in North America whose port does not freeze at all during the winter. The other one is that the town of Valdez, now this is downtown, gets 300 inches of snow a year. Now the surrounding city area, particularly an area called Thompson Pass, gets 900 inches of snow a year. Now, to put that in a little bit of perspective, Jackson Hole, Wyoming, where some of you skiers probably have been, gets about 450 a year. And the last thing is there are no ski lifts where John is. You have to heli ski. There are no ski resorts. There's a company out there where they initially started the heli ski, and a helicopter takes you up there and you ski down to whatever's at the bottom of that. So just some interesting facts, and the floor is yours.
Well, it's a great honor to welcome the new fellows. As you know, this is a program that was really designed to recognize those family physicians that have done that extra bit, and for that, it's a real honor to welcome you into the fold of fellows of the American Academy of Family Physicians. Okay, that's why I got a big iPad so that I can hold it so you guys can see it as well. So, but you do need to raise your right hands here.
Okay.
All right. As a fellow of the American Academy of Family Physicians, I promise to dedicate myself. You repeat.
As a fellow of the American Academy of Family Physicians, I promise to dedicate myself
to the principles upon which our academy was founded.
To the principles upon which our academy was founded.
To providing comprehensive lifelong care to my patients.
To providing comprehensive lifelong care to my patients.
To exemplifying the highest traditions of my profession.
To exemplifying the highest traditions of my profession.
And to enhancing my professional skills through continuing medical education.
And to enhancing my professional skills through continuing medical education.
I pledge my commitment to improving the health of my patients, their families, and communities, and to advancing the specialty of family medicine now and in the future.
I pledge my commitment to improving the health of my patients, their families, and communities, and to advancing the specialty of family medicine now and in the future.
All right. Please, a round of applause for your new fellow. And this is something I think especially is really cool to do within your state. So that's absolutely wonderful.
Thank you very much.
So one of my initial responsibilities, which I guess I didn't do only because everybody else seems to do it wherever you go, is if we could please silence our cell phones. That would be much appreciated as we move forward. Now we have another visiting dignitary here that brings greetings from the Pennsylvania Academy, Dr. Nicole Davis. Dr. Davis is a family physician who practices at Chestnut Hill Family Care Associates in Wyncote, Pennsylvania. Dr. Davis attended the Pennsylvania State University College of Medicine, did a residency training at Montgomery Hospital, and is a past president of the Pennsylvania Academy of Family Physicians. Would you like to come up to the podium and speak so you can face everybody?
Thank you, Dr. Schauer. Good morning. I bring you greetings from the Pennsylvania Academy of Family Physicians and our president, Dr. Edward Zurad. I'm just here to give a brief update on some things that are going on in Pennsylvania. We have a few things in the legislature right now. We have a prior authorization bill, which looks to really get rid of or simplify the prior authorization process. And we have some co-sponsors with that, the Pennsylvania Medical Society, the Pennsylvania Osteopathic Medical Association, and the Hospital Association of Pennsylvania. We also have a sponsor, one of the state senators is sponsoring that bill too. So we're looking forward to moving forward with that. We're also still in our battle with nurse practitioner independence. It's an ongoing, long battle. I actually testified in front of that committee in October of 2015, and it is still ongoing. We don't think it's going to go anywhere this year, but we're still in the fight with nurse practitioner independence in the state of Pennsylvania. Our PDMP, or prescription drug monitoring program, rolled out last year, and it has been, it's a good system. I see that you guys lobbied to get your medical assistants on to get the delegation powers. When ours rolled out, that was already there. Actually, anyone in our office can go in as a delegate under us. So they have to go in and become a delegate for us, and then they have their own sign-in where they go in. But we know that if they are going in, they're looking for us. So it's been a good system for us, and right now we're not looking at any upgrades. Of course, I saw also that you are looking for interoperability with the other surrounding states, and of course, we're probably going to look into that sometime in the near future. The biggest thing that's happened within the Academy in this last year is that we are completely 100% virtual now. Last year, we completed the sale of our building, and all of our employees now work from home. They meet once a week for a 2-hour meeting, and we even have one of our staff members who wanted to move, but we didn't want to let him go. He was a great staff member, and he lives in California. So he Skypes in for the meetings every week. So from a member perspective, when I call, my call gets routed to the same person it was going to get routed to anyway when they had the building, and the staff members really, really enjoy working from home. So I look forward to ongoing conversations with you over the weekend. Thank you for this time.
Thank you, Dr. Davis. Okay. Next on the agenda, always interesting, is the report of the Executive Vice President, right?
All right, we're going to see if we can make this work. You have, this is number 17 for me. Clearly you are all not thinking. You can all look in your report and in the House of Delegates handbook and hear all of the wonderful things that we're doing at the Academy, all of the things that keep us strong financially and keep us working on your behalf. I want to recognize or look at two projects that were clearly a part of our strategic plan and are going to be a part of our strategic plan likely going forward. I know at least this first one is near and dear to Dr. Carazone's heart, and those of you who were in the boardroom yesterday know that. Last year we talked about the videos that we started to create to shed some light on the student debt project. And over my head, you see what is becoming and will be unveiled this week, the first go-around of the website that we've created that houses all of the information relative to our primary care student debt project. I'm going to take you through a little bit of it, but the first thing you can maybe notice is that it's called keepnjdocs.org. You can go there whenever you'd like. Two quick caveats about the website. The website is meant to be dynamic, and that is, once we begin to gather more information, once the task force that Dr. Carazone puts together starts to give us more information, this will grow and evolve. The look may also grow and evolve, but this is the starting point for it. We clearly know what the problem is. And you can sort of flip through that, videos and information about why we are losing primary care physicians in New Jersey. We have other videos that address the problem in New Jersey. Here's my favorite part of the site so far: loan program resources. So for students, for residents, and for physicians who are in the community with a debt burden still, we have information on where you can get some assistance for your loans currently. Not to say that we're not continuing to work on how to find better loan forgiveness and loan redemption programs in New Jersey, how to develop more. We link to our career centers, both the NJAFP Career Center and the ACP Career Center. Remember that this was a joint project of the NJFP and the ACP New Jersey chapters, which is also a very cool collaboration. And I will show you quickly, if I can get back to it. That's Herb's favorite part right there, his little name tag. Hello, my name is $420,000 in student debt. Here's one of our latest videos, and I'm going to show it to you mostly because of the players in it.
Hi, my name is Dr. Sarah Leonard, and I'm a family physician in Freeport, New Jersey. I was born and raised in New Jersey. I grew up in Leonia, and I currently owe over $200,000 in student loan debt after 5 years of repayment. I'm born and raised in New Jersey, and when I was a resident and living in that hallway, I got some offers from other states, particularly Wisconsin. Actually nice areas. People think, oh, Middle America, not much there. Granted, you can't get a good cannoli, but they were actually nice areas, and they were offering to pay me a lot of money. Some of them were offering as much as $200,000 in loan redemption. There were signing bonuses. I didn't get any of those offers in New Jersey.
We need to appreciate the tremendous debt burden that physicians face coming out of school. And if we understand the importance of building a strong primary care network and maintaining that, and recognizing, too, that we're losing primary care physicians with an aging workforce, we need to begin to make investments yesterday.
I think when people say that it's not necessary for the state to help in some way to make it easier for students to manage the cost of their training, because doctors are going to make lots of money and they can take care of it themselves, that's really short-sighted. We don't support medical education because we want to do favors for medical students. We support medical education in our own self-interest. It's in the interests of me and my family. It's in the interests of the individuals and the families who are watching this video, and it's in the critical interest of all the citizens of New Jersey, all 8.6 million of them.
New Jersey is a difficult state to practice primary care in, and I often think about going to other states where they're a little bit more family medicine friendly.
The state has a lot of policy choices at its disposal. It can increase loan redemption programs. The funding for that has been flat for years, and quite frankly is not supporting many physicians, if any physicians at all. Or we can look at it in a way that we look at new home buyers. We support new home buyers with low interest loans, with controls on the amount that they might have to pay in terms of a loan and the interest, because we understand how important home ownership is to communities, their stability, to the schools, to a quality of life overall. Well, a strong physician workforce, particularly in the primary care space, is also important to a quality of life and to healthcare costs overall. And so it's appropriate that the state make investments in the people who we will need to do that important work going forward.
What's so critical about supporting primary care is that health is really everything. If the citizens of New Jersey don't have their health, then all the rest of the talk about quality of life is meaningless.
I would love to see New Jersey help its own.
I particularly like the Law and Order themed music that just keeps us so engaged, or not. One of the best parts of that video for me is it relates back to Dr. Cullen's comment about engaging the legislator. Two legislators on that video who clearly understand the problem. I think one of the things we're going to learn in the coming weeks and months is that we still have to make the case that people actually leave as a result of this. So that'll be kind of the next phase of this, to make the case that, it's not just stuff we talk about. We're going to talk about the people who actually leave here. So that's one piece of the work that we've done this year that's directly related to something that came out of this House of Delegates last year. Now I'm going to try to make this work, but I don't really think I'm going to be able to do it. I'm going to have to go back to my computer. There it is. Can I get to the bottom? Come on, there we go. There we go. I can't see it. I'm going to invite Dr. Cascarina up, who will talk a little bit about a second piece of what we did, which is our membership survey and the results of that survey.
Oh, yeah. I've got a teleprompter, so this should make it a little more understandable. Before I get started, I'd really like to thank the other members of the committee. Kathy Saradarian, who seemed to come up with a lot of our great ideas. Sally Moravchik, who sort of kept us on point. Maria Seminelli, who came in with some very good points, and Vikram Gupta, and Aditi, of course, always helpful, and our pollster, Benjamin Coopersmith. Who was our paid consultant, who really formulated the final form of the survey and then crunched the numbers for us. All right, so I think we've got some slides to look at. All right, so here we go. I don't have to look backwards. Our methodology, we recruited via a SurveyMonkey email. Between March and May of this year. And we got about 130 completed interviews, which our pollster said was a good number. The margin for error was about 8.5%, which means we can take sort of general guidance from this poll. And we can't really look at very specific things, but we can sort of get a gestalt as to what our members are looking for. In other words, we're looking for trends. There was significant concern about the state of family medicine in New Jersey. However, people our members thought relatively positively about the New Jersey Academy of Family Practice and what we do. our members want advocacy and communication, and they want to know that we're making a difference in their practices and in their lives. The concern about the future of family medicine, was clear. And I know this is, close to my heart. Physicians were concerned about the viability of, small practices, physician-run practices. Also worried about what's going on in Washington right now, and, if the gains that we made under the Affordable Health Care Act are going to get, rolled back by what's going on right now. The workforce pipeline, are we going to be able to continue to, train enough family practitioners to do the jobs we need to do? And, a lot of us have invested a lot of time and effort into programs like the Patient-Centered Medical Home. And, most of us have seen some gains, but I think a lot of us hope that we, see sort of more financial gains for ourselves and gains for our patients than what we have seen. And, most of our members, really want to see us fighting on their behalf and our patients' behalf. Interestingly, a lot of the respondents said they'd like to get more involved with the Academy, which kind of surprised me. A lot of the respondents said that they, weren't very involved, but over the next, few years, they'd like to get more involved. So there really is an opportunity to reach out and get more people doing, get more members doing what we're doing right now. But they say it's got to fit into their lives. It's got to be not easy. Well, I guess easy is the term. They need to be able to, we're all very busy. We've got, practices, we've got kids, a lot of us, we've got other responsibilities, and people need to be able to get engaged in a way that fits into their lives. All right. No, that's okay. We're done? Yeah, okay. So, yeah, it was very encouraging. I thought, we've got a membership that does think that we're, making a positive influence on their practice, and that they like that, a membership that like to get a little bit more involved. So hopefully over the next year we can figure out how to get people a little more involved, and help the organization as a whole. So I think that's it.
So my goal was to show you a couple of things that were the product of the work that this house has done or guided us to do over the last year. Are there questions for me, for Dr. Cascarino, on either of those two projects or anything that's going on in the Academy? Good. I always like when there's no questions because I can't usually answer them. If you have any questions, you all know how to reach me, and all the folks up here at the table are certainly accessible as well. I would like to end by, once again, as I always do, telling you that you might have the most incredible staff in the entire chapter family, and as you see those folks walking around, please congratulate them. I have the easiest job in the world because of the folks that work for the Academy and work for all of you. So as you see them, make sure, and I know you always do, but make sure you thank them. And thank all of you. I'm wearing an Indian silk tie and cufflinks today that Dr. Krishna gave me last year. And Dr. Krishna told me today, I told him, I'm going to wear your tie tomorrow. And he said, oh, my goodness, this is the first time in 14 years I won't be at the House of Delegates. I have to be somewhere for a family event. And as I look around the room, there's folks that make Krishna look like a rookie. So thank you for all of your commitment for all the years and this work isn't easy. The work you're doing right now is a day out of your office. The work all of you do who sit on the board and sit up at this table are days and weeks out of the office. And giving back is kind of what that's about, but maybe thank you is in order. So thank you to all of you.
Thank you, Ray. I want to echo the accolades you have put on the staff. And, of course, staff is in a lot of ways a reflection of the leadership of that staff. And to that end, I want to extend those accolades to you also for being our leader at that level for quite a few years. Although if he's seen as a rookie for 14 years, and you must have alluded that some of us tend to be more mature, or shall we say old, and seasoned. Well, I tell you, us seasoned people feel a lot more seasoned than you know that you're old when your back goes out more than you do. So with that in mind, we're going to take a 15-minute break and get back here, and then we'll have nominations, elections, and then we're going to do the resolution presentations. Then we'll have lunch. So let's keep it to about 15, 20 minutes, and we'll see you back here.
I'd like to ask that the secretary begin to keep account of the number of Cirilloisms that the speaker throws out throughout the rest of the day.
It's one. I won't talk about the rake joke. I'll leave that in the bag this year. The rake joke will stay in the bag.